Welcome everybody. I'm Dr. Abdul Latif, Consultant Associate Professor and Head of the Department of Nephrology. Today we will discuss about the glomerulonephritis and few words about the nephrotic syndrome. The glomerulonephritis, that is the inflammation of the glomeruli, and glomerulopathy means the disease of the glomeruli. This is the normal histological picture of glomerulus, and here a picture which shows the filtration membrane, that is the filtration barrier, glomerular basement membrane. One layer is the endothelial layer, this is the endothelial layer, and this is the basement membrane, and this is the epithelial layer. When the plasma or the blood is filtered in glomerulus, it should be passes through this three layer. How a glomerulonephritis or nephrotic syndrome patient is present? The clinical presentation of the glomerular disease, that is the asymptomatic, the first one, the asymptomatic. Usually the proteinuria is less than 3 gram per day. Hematuria, that is the RBC more than 2 high power field, and the RBC, usually dysmorphic RBC is the present. The patient is asymptomatic. The patient come to the health checkup or the others disease process when urine examination is done. The patient, some patient shows their proteinuria or the hematuria, and this group of the patients needs the further evaluation, and sometimes this group of the patients diagnosis as a glomerulonephritis. Most of the patient is asymptomatic and usually disappear within the few days, and some patients has a disease process. And another one is the microscopic hematuria. Macroscopic hematuria. That is the brown, red, painless hematuria. Usually, no clot formation is occurred. That typically coincide with the intercurrent illness. The patient is complained the throat sore, the throat pain, and the fever. And in this time, some patient passes the blood through the urine. This is called the sympharyngitis. Sympharyngitis. And this asymptomatic hematuria and plus minus proteinuria in between the attack. In between attack, patient present থাকতে পারে, asymptomatic hematuria থাকতে পারে, and mild to moderate proteinuria থাকতে পারে. This is the typical presentation of the IgA nephropathy. This one is the nephrotic syndrome. Another presentation, the most common presentation is the nephrotic syndrome and the nephritic syndrome. The nephrotic syndrome, this is the nephrotic syndrome is usually defined as a symptoms of massive proteinuria, that is the more than 3 gram per day. In case of the children, more than 40 milligram per hour per square meter body surface area. Patients hypoalbuminemia, that is the less than 3 gram per dl. In case of children, it is less than 2.5 gram per dl. Patient is grossly edematous, and dyslipidemia, hypercholesterolemia is present. And another, the new word, new characteristic is added, and these are the lipiduria, that is the lipid droplets passes in the urine. These are the typical presentation of a nephrotic syndrome. Another presentation, the nephrotic syndrome is, we may classify the primary nephrotic syndrome and the secondary nephrotic syndrome. The primary nephrotic syndrome is mainly commonly the minimal disease, usually a disease of the childhood disease, and membranous nephropathy, membranous glomerulonephritis. These are the adulthood disease, and the focal segmental glomerulosclerosis. These usually occurs in the adolescence and the early adulthood. And the secondary, the most common one is the diabetic nephropathy. That is the diabetic nephropathy, SLE, amyloidosis, hepatitis B, C induced nephropathy. These are the secondary cause of the nephrotic syndrome. And another presentation, nephritic syndrome. Nephritic syndrome, that is the acute presentation. Usually we say the acute glomerulonephritis, the presentation of the acute glomerulonephritis. Usually occurs in the post-streptococcal glomerulonephritis. The patient is usually oliguric. Patients has the hematuria the hematuria. That means urine. When we examine the urine, there is a red cell cast. Patients is there is a proteinuria, but proteinuria is usually mild. The proteinuria is less than 3 gram per day, and the patient's mild to moderate edema is present. Patient hypertensive. Almost all the patients are hypertensive. It is abrupt onset, when it's sudden onset, and usually self-limiting. After the few days, it's disappear, and disease process is usually become normal. And sometimes, if uh, the pathogenic insult is persist, and this may be continuous, this may be progress, and sometimes this may be progress to the chronic glomerulonephritis, that is the IgA nephropathy, diffuse membranopproliferative glomerulonephritis. This group of the patient, SLE, sometimes present with the nephritic syndrome. And the most common presentation হলো nephritic syndrome post streptococcal glomerulonephritis, the infectious glomerulonephritis, infective endocarditis. This group of the patient is present with the nephritic syndrome. Nephritic syndrome, the primary nephritic syndrome and the secondary nephritic syndrome, that is primary nephritic syndrome post-infectious, that is the diffuse proliferative glomerulonephritis, usually the post-infectious post-streptococcal glomerulonephritis. Membranoproliferative glomerulonephritis is another one. IgA nephropathy and the crescentic glomerulonephritis, that are the rapidly progressive glomerulonephritis. Secondary causes ভিতরে most important হলো Henoch-Shenley purpura systemic vasculitis, that is the ANCA associated vasculitis. ANCA associated vasculitis with organic glomerulomatosis, membrane Church-Strauss syndrome, তারপরে microscopic polyangiitis. That is the SLE, another important, and systemic sclerosis, less important one. How will you differentiate between the nephrotic syndrome and the nephritic syndrome? The nephrotic presentation and nephritic presentation, these are the most important part in the examination. In nephrotic syndrome, the onset is usually insidious onset. That is, it is gradually developed. The patients initially presents with reduce the urine output. Gradually, the patients develop the edema, and it's gradually increasing and increasing. And nephritic syndrome, it is the abrupt onset. দেখা যাচ্ছে যে patients early morning, sometimes patients is complain is passes the high color urine, and gradually in the evening times is develop for the edema and the puffiness of the face, and the patients tachycardic and the hypertensive is also. The edema in nephrotic syndrome, edema is the grossly edematous patient. Grossly edematous patient. In nephritic syndrome, edema mild to moderate edema is the present. In nephrotic syndrome, blood pressure is usually normal or upper limit of the normal, and the nephritic syndrome, almost all patients are hypertensive. Almost all patients are the hypertensive. Proteinuria, nephrotic syndrome proteinuria বলছিলাম যে massive proteinuria, it is the more than 3 gram per day, and the nephritic syndrome proteinuria is mild to moderate proteinuria, usually less than 3 gram per day. 3 gram per day. JVP, nephrotic syndrome JVP may be normal or the low, and nephritic syndrome rest JVP. JVP is the rest. Hematuria, nephrotic syndrome hematuria may or may not occur, but in nephritic syndrome, hematuria is the more common findings, the most common findings. Usually, all the patients is the hematuria present the RBC in their urine, and there is a RBC cast. And red cell cast. Nephrotic syndrome, red cell cast is absent, and in nephritic syndrome, there is a cast is present. Red cell cast or the WBC cast may be present. Serum albumin is low in nephrotic syndrome due to the massive proteinuria. The liver cannot cope to produce the adequate amount of the albumin, so albumin level become low, and the patients develop the grossly edema. And in case of the nephritic syndrome, the serum albumin is slightly reduced or within the normal limit. Another clinical presentation, the rapidly progressive glomerulonephritis. Rapidly progressive glomerulonephritis, this is the one kind of the AZN, that is the nephritic presentation. This group of the patients have developed the renal failure over the days to weeks, and hematuria is the present hematuria, and there is also the red cell cast or the WBC cast. Proteinuria usually mild proteinuria, BP often normal. That is, there is no adequate time to develop the volume overload and the hypertension. This patient's group of the patient, though it is present with a nephritic presentation, but the patient's BP maybe within the normal limit, may have other feature of the vasculitis. Vasculitis patients what we present with the rapidly progressive glomerulonephritis. These patients may present with the hemoptysis, pharyngitis, otitis media, skin vasculitis, skin rash may be present. And last presentation of chronic glomerulonephritis. This group of the patient is usually present with the young age group of the patients with no health checkup group of the patient. Young patients, this patient is hypertensive, you don't know. This has a renal impairment, you don't know. But this proteinuria is usually more than the 3 gram per day, and already the kidney is the shrunken and smooth kidney. Shrunken and smooth kidney. The shrunken and smooth kidney size is reduced. There is a medullary differentiation is the loss. So the presentation is asymptomatic presentation, macroscopic hematuria, nephrotic syndrome, nephritic syndrome, then rapidly progressive glomerulonephritis and chronic glomerulonephritis. So these are the classical presentation of a glomerulonephritis patients. The glomerulonephritis patients, this patient has an active urine sediment, dysmorphic red blood cell or red cell cast থাকতে পারে, hyperalbuminuria, lipiduria, hyperlipidemia, edema, abnormal renal function, and the hypertension may be present. How we classify the glomerulonephritis? There is a histological classification, that is the focal. Focal means the some glomeruli is involved, less than 50% glomerulus is involved. Diffuse means the wall the glomerulus is involved, that means the more than 50% glomerulus is involved. And segmental, the part of the glomerulus, that is glomerulus is a tuft of the capillary. The only one part of the glomerulus is the involved here, and the global, the interglomerulus is the involved. Interglomerulus is the involved, and another one is the primary and the secondary glomerulonephritis. The primary renal disease, that is the only the kidney is the involved. And the secondary, the systemic disease, its complications last it involved the kidney, that is diabetes, diabetic nephropathy, and the SLE may be involved the lupus nephritis. So classification, primary glomerulonephritis and the secondary glomerulonephritis. There is a two types, both primary or the secondary glomerulonephritis. One is the proliferative glomerulonephritis and another is the non-proliferative glomerulonephritis. Proliferative means that presentation is usually the nephritic presentation, and non-proliferative glomerulonephritis, their presentation is nephrotic presentation. So the primary proliferative glomerulonephritis, IgA nephropathy, membranous proliferative glomerulonephritis, diffuse membranoproliferative glomerulonephritis, messenger proliferative glomerulonephritis, this group of the patients. And the secondary non-proliferative glomerulonephritis, primary glomerulonephritis and non-proliferative, that is the membranous glomerulonephritis, that is the membranous nephropathy, minimal change disease, that is the MCD, and the primary focal segmental glomerulosclerosis, FSGS, and other less important, the fibrillary glomerulonephritis, immunotactoid glomerulonephritis is the present. The secondary cause of the proliferative glomerulonephritis, that is the this group of the patient is present with the rapidly progressive glomerulonephritis. Rapidly progressive glomerulonephritis present করে থাকে. These are most important is the Goodfast syndrome, anti-GBM antibody related disease, anti-GBM disease, anti-glomerular basement membrane disease, that is the Goodfast syndrome হিসেবে present করে থাকে. Goodfast syndrome, renal involvement as well as the involvement of the lungs. Renal vasculitis, that is the ANCA-associated vasculitis, Ogner's granulomatosis, microscopic polyangiitis, Church-Strauss syndrome. Lupus nephritis is another important cause of the presentation of the secondary glomerulonephritis. In proliferative varieties, and bacterial endocarditis, Henoch-Schindler purpura, and the most important is the post-infectious glomerulonephritis. And non-proliferative, secondary non-proliferative diabetic nephropathy, hypertensive nephrosclerosis, amyloidosis, light chain disease, that's the multiple myeloma, and secondary focal glomerular sclerosis, that is the obesity-related or other drug-related cause of the focal segmental glomerular sclerosis may present with the secondary cause of the non-proliferative glomerulonephritis. যারা আপনারা যারা আছেন যে proliferative non-proliferative ভাগ করে বলতে না পারবেন, তারা শুধু এইভাবে বলে ফেলবেন যে glomerulonephritis, primary glomerulonephritis, minimal change disease, membranous, focal segmental, membranoproliferative, diffuse proliferative glomerulonephritis, crescentic glomerular. Secondary ভিতরে SLE, diabetes mellitus, amyloidosis, Goodpaster syndrome, and vasculitis, and hereditary Alport syndrome. Pathogenesis of the glomerular disease, that is an immune disorder which involves the kidney and injury by inflammation or other mediator and leads to the glomerular dysfunction. These are the sequence of the pathology. That is some immune disorder, the first, which involves the kidney and it leads the inflammatory or complement activations, and ultimately it's injured the glomerular basement membrane, that is the epithelial layer, endothelial layer, or the basement membrane itself, and leads to the proteinuria, hematuria, or abnormal constituents of the blood passes through the blood to the urine. Immune disorder, that is the immune disorder, that is immune complex, circulating immune complex, or the in situ immune complex, and another is the cell mediated immune disorder. These are the immune disorder pathogenesis. It is the circulating immune complex nephritis, type 3 hypersensitivity reaction. Antigen is the present, antigen is not in glomerular origin, antigen is not in glomerular origin, and intrinsic and antigens may be from the body's part or from the external, that is the post-streptococcal glomerulonephritis, hepatitis B, and malaria. Here the antigen is come and antibody is the developed in the body. Antigen antibodies meet with the circulation, there is a formation of the complex, and this complex trapped into the glomerulus, and it ultimately activates the complements and inflammations and leads to the injury to the epithelial layer, endothelial layer, or basement membrane. Here the two model, one is the antigen is the trapped first in the glomerular capillary, and the circulating antibody is the form. This antibody is then attached with the antigen in the glomerulus, and there leads to the antigen antibody complex, and ultimately it's induce the cascade reaction, that is the complement activation, inflammation, and the others. In situ immune complex nephritis, in situ intrinsic অথবা এক্সট্রিনসিক, ইন্ট্রিনসিক ভিতরে যেমন SLE হতে পারে, এক্সট্রিনসিক অথবা প্ল্যান্টেড। এক্সট্রিনসিক অ্যান্টিজেন্স, ইটস antigens come from the outside the body. It may be infectious one or the others toxic substance which the first implant into the glomerulus, and antibody is the form. And cell-mediated sensitized T cell or the suspected T cell, mediators cell, and the plasma product. Mediators cellগুলোর ভিতরে আছে neutrophil, monocytes, platelets, epithelial cell, and the plasma product এর ভিতরে direct cytotoxics by the antibody, the fibrin-related product, complement activation, and the complex membrane complex attack. Glomerular response to the injury. There is a antigen antibody, whether it is formed into the complex is formed into the circulation or in situ, they leads to the cascade reaction, inflammation. How the glomerulus response? Here the glomerulus response, the increased cell by hypercellularity seen in inflammatory disease. The proliferation of the mesangial and endothelial cell, inflammatory cell is infiltrated within the glomerulus and the mesangium, and the proliferation of the epithelial or the crescent formation by crescentic nephropathy. Matrix or connective tissue, here the hyalinization, accumulation of the pink homogeneous material, plasma protein, basement membrane or the mesangial matrix accumulation eventually lead to the fibrosis. And the basement membrane thicken capillary loop and increase the glomerular basement membrane or the immune deposit into the glomerular basement membrane, given IgA nephropathy. Workup of the glomerulonephritis, the first wall of a patient with the glomerulonephritis present to us, we will do the simple urine test. If there is a proteinuria or there is a RBC, then we go the others test to find out the cause, or a primary or the secondary cause. If there is no secondary cause, then another test is the renal biopsy to confirm the classify the disease process, or already the how much the kidney is involved, or the if there any chance to recover with treatment. Kidney biopsy routine processing, that is the immunofluorescence, electron microscopy, and light microscopy. In our country, we can do the light microscopy and the immunofluorescence test. Direct immunofluorescence test, electron microscope is not available in our country. It is the light microscope feature of the glomerulus. That is the immunofluorescence, the formation of the immune complex with deposition of the antibody in the glomerulus. That is, antibody is the IgG, IgM, IgA, basement membrane or the mesengium deposition होते पारे, linear or the granular pattern होते पारे. Electron microscopy senses the podocyte, food process of the podocyte, membrane, basement membrane thickening, membranous nephropathy, the thickening of the basement membrane, and the mesengium. It's delicated good. The location and the presence of the immune deposit, that is the subepithelial, that is the in between the basement membrane and the epithelium, that is the subepithelial, endothelium layer and the basement membrane, in between the endothelium and basement membrane, subendothelium, and within the basement membrane, that deposition is water. The general management of the glomerulonephritis, there is a glomerulonephritis type of the management. One is the specific management, another one is general management. Most of the patients is recovered with the general management. Some disease specific treatment is the present. Minimal change disease, the steroid sensitive. So there is no option to wait and see. When the patients diagnose a case of the minimal change disease, give the steroid, and the almost more than 95% patient response with the short course of the steroid. So no delay to treat the patient. And sometimes some patients, focal segment glomerulosclerosis, membranous nephropathy, if there is the proteinuria is less, the patient's renal function is stable, patient is not hypertensive, so much hypertensive. In this group of the patients, we can wait and to see at least the 6-month observation period by giving the antiproteinuric drug, ACE inhibitor or ARB or atorvastatin. So the general principle should always be ascertained that glomerulonephritis is the primary. There is that no specific therapy is available. In this group of the patients, general treatment is the best one. The treatment of the underlying infection or the tumor may result in remission of the glomerulonephritis. If the secondary cause is the present, the secondary cause is treated, then glomerulonephritis is resolved spontaneously. That is the infectious or any tumor-related glomerulonephritis. General supportive treatment and the disease-specific therapy. General supportive treatment measures the treatment of hypertension, reduce proteinuria, control edema, address other metabolic consequences of the nephrotic syndrome, treat the infection, avoidance of the nephrotoxic substance. These are the 6 main headlines for treating the patient of a glomerulonephritis. General supportive treatment, if successful, this relatively non-toxic therapy can prevent need for the aggressive immunosuppressive drug. Immunosuppressive drug has a multiple potential side effects. So we first try to giving the non-toxic therapy. If needed, or the disease process is not improved, then some glomerulonephritis needs the immunosuppressive drugs. Supportive therapy is usually not necessary in steroid sensitive steroid sensitive minimal change disease with rapid remission. IgA nephropathy, Alport syndrome, and thin basement membrane disease. Here, the thin basement membrane disease, and these are the benign disease. Usually, there is no chance of the renal failure. And minimal change disease patients may develop the remission or relapse, but this group of the patient usually not develop the renal failure. But IgA nephropathy and the Alport syndrome, these are the Alport syndrome patients usually die within the 21 years. These are the familial disease. Familial disease is usually associated with the sensitive neural deafness, and the male patients is predominantly affected. The female may also affect. IgA nephropathy, it is this group of the patients present with the hematuria, mild proteinuria. Usually long time, these are the asymptomatic, and the patients gradually develop the hypertension, and it's progressively progress, and at a time, patients may develop the renal failure and may need the dialysis. So, provided that the patient exhibits the no proteinuria, normal GFR, and no hypertension, no need of the specific therapy. The measurement of the hypertension is very common in glomerulonephritis. More than 80% patients are the hypertensive in the glomerulonephritis group of the patient, especially the proliferative glomerulonephritis. Virtually universe as chronic glomerulonephritis progress to the ESRD. যে সমস্ত পেশেন্টগুলা গ্লোমেরুলোনেফ্রাইটিস থেকে 3 মাসের বেশি পার করে ফেলছে, যে তার রিমিশন হচ্ছে না, this group of the patient has a chance to the develop ESRD. ESRD, the patient which group of the patient is progressed to the ESRD, মানে end-stage disease, this will be depend on the some factors, and one is the proteinuria. If the proteinuria is the massive proteinuria at the presentation, this group of the patient will progress to the renal failure is, and then the patient who are present with the less proteinuria. Renal function, but that is the GFR, serum creatinine level at the presentation. If the serum creatinine level at presentation is the high, their chance to the progress to ESRD is more. And the response to the treatment. If the patient is response to the treatment, this group of the patients may reverse the disease process. And if not response to the treatment, and this group of the patients may develop the end-stage renal failure. The key modifiable factor is preserving the renal function. So we should preserve the renal function. Sodium and water retention is the important part of the pathogenic process of hypertension is GNA. So we should focus about the sodium and water. So high dose diuretics and moderate dietary sodium restriction is usually essential part of the management of hypertension. Target level of the blood pressure বলতে হচ্ছে যে MDRD হলো modification of the diet in renal disease study. Then proteinuria is more than 1 gram per day, that is BP is less than 125/75. Lifestyle modification should be integral part of the therapy. The salt restriction, 100 millimole per day. Salt should be 6 gram sodium chloride. Weight reduction, BMI should be maintained 18.5 to 24.9 kilogram per square meter body surface area, and regular exercise at least 30 minutes per day, most of the days in a week. Then desk eating planning, dietary approach to stop the hypertension, adopt a diet rich in the fruits, vegetable, and low-fat dairy products with reduced contents of the saturated and the total fat. And stop cessation of the smoking, and moderate or stop the alcohol intake. The men limit 2 drinks per day, and women or the lighter weight men limit 1 drinks per day. These are the approach to the drugs. Step by step, we add the antihypertensive drug. If the age is less than 55 years, then the AC inhibitor or ARB is the drug of the choice. If the age is more than 55 for the black person or the African, the choice of drug is the calcium channel blocker. Step 2 the add on the AC inhibitor and calcium channel blocker, and step 3 AC inhibitor, calcium channel blocker or the diuretics. Drug of choice in case of the glomerulonephritis, the first choice AC inhibitor or ARB. It reduces the proteinuria 40 to 50% in a dose dependent manner. That is, target proteinuria আমাদের হলো less than 0.5 gram per day, and AC inhibitor or ARB may reduce the GFR up to the 20% is acceptable. If GFR is reduced more than 20%, then we should stop the drug AC inhibitor or ARB and give the alternative drug. And non-dihydropyridine calcium channel blocker is the another choice. We can add drugs by sequence. If the first drug is AC inhibitor and it's titrated upwards, if target is not acid, then the second drug. If the no proteinuria at the amlodipine, if the proteinuria is the high, then drug is the diltiazem or verapamil. If target is not acid, then diuretics can be added. If the potassium level is the high, avoid the AC inhibitor, spironolactone. Control of edema. The control of edema, first we should restrict the salt, the moderate restriction of the salt, and if the salt restriction is not adequately alone, then we should add the oral loop diuretics is the first. Furosemide 40 milligram BID or bumetanide 1 milligram 2 times per day. If no response, the double the dose until the diuresis or the ceiling dose, that is the furosemide 250 milligram, that is 12 hourly, that is the 500 is the ceiling dose. That is when above this dose there is no adequate benefit. If no response, add the thiazide diuretics. If no response, IV bolus loop diuretics may be given. If no response, there is a 20% albumin, and then IV loop diuretics. Then last resort is the ultrafiltration. This is a process of the hemodialysis process. Other metabolic consequences with hypoproteinemia, hypercoagulability, and dyslipidemia. This should be treated. Hypoproteinemia, adequate dietary intake. Adequate dietary protein intake, usually protein intake is 0.8 to 1 gram per day, and should ensure the high carbohydrate intake. And when the very high proteinuria, loss amount, that is the 10 gram proteinuria, should be added with the measured amount of the daily protein. If the patient's 60 kg is weight, that is the 60 gram is protein is needed per day. If he passes the 10 gram protein per day, then it's 6 plus 10, that means the 70 gram protein should be taken per day. If severe uncontrolled or life-threatening hypoproteinemia is the present, then we can close the leakage. That is the we can do the nephrectomy. This can be done by medical nephrectomy with nephrotoxic drug, NSAIDs, AC inhibitor, or diuretics with a combined, and that is the bilateral renal artery embolization or bilateral surgical nephrectomy করে আমরা লিকিংটাকে প্রিভেন্ট করে তাকে সেভ করতে পারি. This is the last resort of the treatment, and this patient should be maintained on dialysis in rest of the life, or a low transplant if the primary disease is pure. Hypercoagulability, the nephrotic syndrome patient is more prone to develop for the deep vein thrombosis. The prophylactic anticoagulation is needed with low molecular weight heparin or the warfarin. If the serum albumin is less than 2 to 2.5 gram per day immobility or intercurrent illness. The indication of the full dose or the long-term anticoagulation. If the serum albumin level is less than 2 gram per dl with one of the following, that is if the proteinuria is more than 10, BMI is more than 35 kg per square meter body surface area, familial history of the thromboembolism, newer classification of the heart failure, that is the class 3 and class 4 heart failure, congestive heart failure, and recent abdominal or orthopedic surgery or prolonged immobilization. Albuminemia, hypoalbuminemia, and one of the below 6. If the present, these patients should be given to the anticoagulation and need the long-term anticoagulation. The long-term anticoagulation, contraindication of the anticoagulation if the patient is uncooperative, that is bleeding disorder, prior GI bleeding, CNS lesion prone to the hemorrhage, defective porphyrin metabolism, this group of the patients no need to the anticoagulants. Now, কতদিন পর্যন্ত আমরা অ্যান্টিকোয়াগুলেন্টের আইএনআর মানে আইএনআর মেনটেন করব 2 to 3 within the 2 to 3. If more than 3, doses should be reduced. If less than 2, dose should be raised. And up to the serum albumin level become more than 3 gram per day. আমরা ততদিন পর্যন্ত এটাকে চালাতে হবে যতক্ষণ পর্যন্ত serum albumin level become more than 3 gram per dl. Dyslipidemia is the another one. Dietary restriction of the fat and the cholesterol, statin, fibrates, and cholestyramine reduce the low density lipoproteins and increase the high density lipoproteins. And it's usually the cholestyramine is usually less tolerant. So statin and the fibrate is the mainstay of treatment in dyslipidemia. Dietary protein intake should be maintained with the high carbohydrate intake to maximize the utilization of the protein. Treatment of the infection, ইনফেকশনের ক্ষেত্রে আমরা বলছিলাম যে নেফ্রোটিক সিন্ড্রোমের পেশেন্টস উইথ অ্যাসাইটিস মোর প্রোন টু দ্য সাবঅ্যাকুট ব্যাকটেরিয়াল পেরিটোনাইটিস, স্পন্টেনিয়াস ব্যাকটেরিয়াল পেরিটোনাইটিস, more prone. If repeated infection, the measure of the IgG level, if less than 6 gram per liter, that is monthly, the IV Ig can be given. Vaccination, pneumococcal vaccination 5 yearly, influenza vaccination annually দেওয়া যাবে, and live vaccine, that is the measles, mumps, rubella, varicella, rotavirus, yellow virus infection, এই সমস্ত ভাইরাসের ইনফেকশন গুলাতে contraindicated থাকবে when the immunosuppression, when on immunosuppression with the cytotoxic agent and prednisolone doses more than 20 gram per day. ইমিউনাইজেশন করা যাবে কখন? লাইভ ভ্যাকসিন দেওয়া যাবে যদি সাইটোটক্সিক ড্রাগ না পায়, অ্যাটলিস্ট 3 মান্থ সাইটোটক্সিক ড্রাগ বন্ধ থাকবে, এবং প্রেডনিসোলোনের ডোজ যখন আপনার 20 মিলিগ্রামের পার ডে নিচে আসবে তখন লাইভ ভ্যাকসিন দেওয়া যাবে। Otherwise, live vaccine is contraindicated during the immunosuppressive, that is a cytotoxic agent or the prednisolone dose is more than 20 gram per day উপরে থাকলে contraindicated. After the 1 to 3 months of the cytotoxic therapy, the live vaccine can be given. So, stay home, stay safe, use masks, frequent hand washing, and maintain the distance. Goodbye. আমি শেষ করতে পারছি না বেশি সময় লাগছে?